So I'll be talking about the advances in breast imaging. So and this is like really in future outlook, what is there, and like the motivation for advancing ourselves and not just sticking with what has been done in the past is that a one-size-fits-all approach has been shown that to in particular in breast not to work, because we do not have an average patient. Yeah, we used to have like offering all the treatment to everybody with potential toxic side effects and with disappointing outcomes. So we now really, in particular in breast, tailor our treatments to the patient. And this is basically the idea of precision medicine, which takes into account that patients are different from their makeup, from how they live. So, and when we look at precision medicine, there is integral to that is a systems biology approach, which is study of complex biological systems, the interactions, temporal and environmental changes. And it uses, as we have heard here multiple times, computational and mathematical modeling to integrate all these information, and it crosses over multiple disciplines. And of course, last but not least, imaging. Imaging is a very integral part nowadays in that. So we are no longer just a photographer who takes a picture and that's it. And in breast imaging, lending itself to this is MRI of the breast. It is the backbone of any MRI protocol, the DCE. We have 3D morphologic and functional information, but there is more to MRI than just DCE. Yeah? This is like would be an example where we have a patient high resolution protocol. We see an irregular mass with kinetics that are not entirely benign. So you will have to recommend a biopsy. Turns out it's complex sclerosing lesion with ADH with no upgrade on surgery. So we will generate false positives where we can, of course, discuss, wasn't it better that that came out anyway? But we are still doing unnecessary benign biopsies in patients, and we want to make us better. So there are ways of improving ourselves, and one which is actually already there and implemented in the clinics is basically from a temporal resolution point of view. This used to be the standard protocol, the FAST protocol, where we have multiple time points post-contrast, but in my institution we're actually using the faster measurements, and in some institutions there's the ultra-fast approach. Whatever you do, this either fast or ultra-fast will make you better. I prefer the faster protocol simply because I keep my spatial resolution the same throughout the whole sequence, whereas in the ultra-fast you usually have an ultra-fast block in the first minute where you see the cancer enhancing rapidly, and then they have to add on high resolution blocks that give you then the good spatial resolution. And this was basically one of our first examples. This patient actually had...
So we'll wrap up the last large session with going through some cases, hopefully some bread and butter cases, as well as some interesting and maybe a little bit quirky cases. As Dr. Ojeda said, I've recently retired from the Navy. I was at the Naval Hospital here in town and trained at Mayo for my fellowship. So let's do some cases. So fairly straightforward here. We've got a 67-year-old who came in for screening exam, and we've got a hyperdense mass. So we're going to want to get an ultrasound. And here's what we see: a nice hyperechoic, circumscribed, parallel mass, maybe some mixed acoustic characteristics deep to it. And this is a fairly straightforward case. Hopefully I'm not insulting anyone here. But priors are worth their weight in gold in our business, and here's our priors. And this is a simple case of a hyperdense mass that's residual silicone granuloma, or probably in a lymph node from a post-explantation patient. So we often don't get a very good history in radiology, especially if you're on the ER side, if you read general as well as breast. And a little history goes a long way, but priors can go even further. This case has already been discussed a little bit by Dr. Raquel Penner, and this is a young lady who recently presented for her baseline screening. She was African American, so obviously it increased for an earlier and more aggressive cancer, and she ended up having this focal asymmetry on her baseline. And I only brought this up because this is one of those things that you don't necessarily see all that often, and you can forget that it's one of those 3 lesions where you can follow it safely as long as it meets the criteria. 0.5 to 1% chance of malignancy. She had negative ultrasound. She had no architectural distortion, completely negative workup. We originally decided to follow it. She had a family history that was a little bit concerning, that was not a primary relative. So she ended up having a tomo-guided biopsy, and it was benign breast tissue, and we'll see her back in 6 months just for a follow-up. Again, unlike with calcifications, we can't image our specimen afterwards and have a great check on that we got the calcifications, but we can see where our clip is, and then we follow them up to make sure that we don't get a false negative. This is we get a lot of transfer of care at the U, a lot more than they did at Navy. And this is a 61-year-old who came to us actually from Mexico. And if you take a look at her mammogram here that we repeated when she showed up, I'll give you a minute to take a look at it.
This is a topic that I just really love, and I'm very fascinated by it. Here again, my industry conflicts. So what we're going to talk about is sort of the explosion of genetics and understanding the genotype and the individual personal genome. And then we're going to sort of cover integrating how does that interface with the phenotype, which is what we deal with a lot with the imaging and the pictures. Okay, so I actually think we're living through one of the most fascinating and exciting times in medicine. We are really in the fourth industrial revolution right now, where it's all about digital and using digital for not only, cyborgs and other things like that, but in medicine, really incorporating that and using it to its full extent. So I think, as far as change, we all have to be really aware of change management and adaptability and flexibility, because I think our roles as radiologists in the next 10 years are going to change, incredibly. It was only 15 years ago that the whole human genome was sequenced, and it was a collaborative effort between private industry, which was Craig Venter, and the NIH with Francis Collins. And it was to the tune, they basically sequenced the entire human genome. They used, I think, 12 or 13 reference individuals for that. And it was to the tune of $1 billion. Okay, so it took over $1 billion to completely sequence the entire genome. And so this really opened up this era of, personal treatment. At the time, Obama launched a big personal medicine initiative, and there was a lot of hope that if we could find the mutated genes in these cancers, that we could basically cure cancer. And so there was a Time magazine article about CLL and Gleevec, and the fact that in this particular cancer, there's really only one driver mutation, and it's a tyrosine kinase. And so Gleevec targets that one specific mutation, and it took a cancer that was uniformly fatal, and it made it into a chronic disease, as long as you take your daily Gleevec pill. So that was a silver bullet, and that was remarkable. But not all cancer is that simple. In fact, most cancers have multiple.